Welcome back to Oral Path. I am Professor Richardson. In this video, I'll be discussing the fundamentals of a variety of neoplasms. Much of the terminology in this lecture should be familiar to you from my previous lectures, but I'll include some pop-ups along the way for a refresher. Let's get started. So what do we mean by neoplasm? Well, that simply means that there is a new growth of cells which are abnormal. The term neoplasia does not define whether that growth is benign or malignant. So we do classify tumors into those two categories, benign and malignant. Benign lesions are usually well differentiated. They grow very slowly, they rarely have mitotic features, and they're usually encapsulated, whereas malignant tumors can be differentiated or anaplastic, which means that they have no resemblance to normal cells. They can be slow growing or have rapid growth. They may have numerous mitotic figures, and they are typically invasive and unencapsulated. So we would see with benign lesions, they do not metastasize, whereas malignant lesions do metastasize. So you're going to want to know the difference between what benign features are versus malignant features. Now, what is in a name? When we dissect the names of various types of neoplasms, we can gather clues as to their identity. The prefix is going to tell you what type of tissue or cell is being affected, and the suffix is going to tell you that it is a tumor of some sort. If we look at this example, a lipoma, the first part of this word indicates that it involves fatty tissues or adipose tissue because lip or lipo is the prefix for fat. Oma indicates that there is a tumor. So this one means that there is a fatty tumor. As you learn about each of these neoplasms, remember to look toward the name for clues of its origin, and that should help you narrow your answers down. Now, the type of treatment involved is also going to depend on what type of tumor is present. With a benign tumor, these are usually going to be surgically removed. Typically, a surgeon will attempt to remove that lesion without actually cutting into the lesion itself. That is what we call enucleation. So they're going to try to remove a portion of healthy tissue surrounding that lesion as well, in order to ensure that they've removed the entire lesion. That is what we call wide local excision. With malignant tumors, we will see a wider variety of treatments, which involve usually surgery to remove the tumor if possible. And then we have differing types of chemotherapy, radiations, and some of the latest treatments involved in cancer would include immune modulators, which are really aimed at harnessing a patient's immune system to achieve tumor control and possibly eradicate the disease. There's been a lot of advances with malignancies and how to treat those malignancies in the last couple of years even. If you remember back in oral anatomy, we learned about the different types of epithelium. There's a variety of tumors which can arise from the epithelium, but in the oral cavity, we're going to discuss those that arise from squamous epithelium, those that arise from salivary gland epithelium, and those that arise from odontogenic epithelium. We're going to start by talking about neoplasms of the squamous epithelium, and there are 4 neoplasms in this category: papilloma, squamous cell carcinoma, verrucous carcinoma, and basal cell carcinoma. We've already discussed papilloma, so this one should be more of a review. Some of the words that we use to describe papilloma would be exophytic, meaning that it grows outward. They can have pedunculated or a sessile base, but microscopically they're going to have finger-like projections. In this lesion, you can actually see the finger-like projections because they're very prominent and visible. They're also described often as cauliflower-like. So they're going to be pale or white, and the whiteness of the lesion is going to depend upon the amount of keratin present. Let me say that again. The whiteness of a lesion depends on the amount of keratin present. These lesions are going to be surgically removed with special care to remove the base so that the lesion does not recur. Now, clinically, a papilloma can resemble a verruca vulgaris or a condyloma acuminatum. So often pathology examination is warranted to allow for a definitive diagnosis. That's one of the reasons we want to have those surgically removed, refer them to the oral surgeon. Now here we're going to have our very first board alert right off the bat. First board alert, squamous cell carcinoma is the most common primary malignancy of the oral cavity. Squamous cell carcinoma is the most common primary malignancy of the oral cavity. These lesions are going to appear as exophytic again, and they're going to be ulcerated masses. They're going to be malignant and invasive. They're capable of destroying soft tissue and bone. With squamous cell carcinoma, we may see leukoplakia, erythroplakia, or a mixture of both. I once had a patient I'd been seeing for many years who presented with a leukoplakia on the lateral border of his tongue during a routine visit. I know I've said this many times, but guys, you're never going to find what you're not looking for. I did an intra-extraoral evaluation on every single patient in my chair during every visit, back before it was actually popular to do so, even if they came 4 times a year. Now, the lesion on this gentleman's tongue was very small and really kind of inconspicuous, but it was on my radar for several reasons. First, it was on the lateral border of the tongue. Most squamous cell carcinomas occur on the lateral border of the tongue or on the floor of the mouth. So here is your first submission question. Where do most squamous cell carcinomas present intraorally? Okay, back to my story. The second red flag I had with this patient was that he was a smoker, which also increased his risk. So out of an abundance of caution and in consultation with the dentist, we decided to have him come back in 2 weeks for a recheck. And at that 2-week mark, the lesion was still there. It had not grown in size, but it had not healed either. So we went ahead and sent him to the oral surgeon. They excised the lesion and performed biopsy, and it came back positive for squamous cell carcinoma. Had I not been looking for this, it's very likely that he would have gone undetected for months. Excuse me. The general rule of thumb with anything abnormal or suspicious is to reevaluate in 2 weeks. Now, remember in a previous lecture, I talked about actinic colitis, which is an epithelial dysplasia that's associated with a higher risk of squamous cell carcinoma on the vermilion border of the lip. So we know that tobacco and sun exposure are significant risk factors for cancer, including squamous cell carcinoma. The treatment is going to depend on what stage the tumor presents and can include any combination of excision, chemo, radiation, and like I said, treatments are evolving all the time. Now, one thing I want to note about staging, I do not intend for you to know the ins and outs of how to stage tumors, but I want you to have a fundamental understanding of what staging means. And I really like this graphic because it's very oversimplified. But you don't need to really know any more than this. Staging can be anywhere from 0 to 4. Your text may say anywhere from stage 1 to 4. But anytime a tumor has distant metastasis, what does that really mean? That means that the tumor has now branched off and is presenting in another area. For instance, if you have your primary cancer is breast cancer, but now you have a breast cancer in your hip, that would be distant metastasis. And anytime you have a distant metastasis, then that's going to put you into stage 4. And so prognosis tends to go down the higher the stage of cancer that you have. If you were going to have any type of oral carcinoma, verrucous carcinoma is probably the one you'd want to pick. Now, this picture looks pretty gnarly. I mean, this one's a pretty advanced verruca. But it rarely metastasizes, so it does have a very good prognosis when it's caught early. These are also wart-like, so they do get confused with papillomas, but they are very slow growing. They're exophytic, and they sometimes have a pebbly appearance. They can appear white due to keratin plugging, or they can be a red or white mixed. Remember, we said the more white a lesion is, the more keratin there is. The treatment for these would be excision, and so that's a very successful treatment for this type of cancer. Basal cell carcinoma is another one that is associated with sun exposure, so we don't really see basal cell carcinoma intraorally. You'll find these lesions from time to time, especially on your older patients, and we do see them often on the ears or the nose because those areas are more exposed to the sun. And while they rarely metastasize, they are very locally destructive. So anytime you have an ulcer that persists again for 2 weeks or longer, it needs to be evaluated by an oral surgeon. I remember when I was in hygiene school and our clinic dentist was adamant about checking behind the ears of every patient. That really stuck with me, and I've been able to bring many suspicious lesions to the attention of the dentist over the years. The treatment is going to involve surgical excision, but if the lesion is larger, sometimes radiation is required. There are new medications even for these types of cancers that they have where they can catch them much earlier. Like I said, you don't need to know the ins and outs of that. What you need to be concerned with is being able to identify something that is abnormal and make sure that it is brought to the attention of the dentist so we can get that patient referred. Pleomorphic adenomas are benign salivary gland tumors which account for 90% of all benign salivary tumors. These tumors are encapsulated and they contain a mixture of epithelium and connective tissue. So they're often called benign mixed tumors. They are sometimes difficult to remove completely, which leads to recurrence in some cases. I had a patient with a pleomorphic adenoma once, and it looked very much like the first picture in this slide, but not quite that large. He had had this lesion fully evaluated, and he went for checkups periodically at the oral surgeon. He actually chose to not have it removed because the destruction it would leave at that time, he would probably lose some teeth. And the fact that it was benign and it was likely to recur if they couldn't remove it all, he just decided to leave it. He did have a hard time keeping those teeth clean though, and he eventually did lose all those teeth and ended up with a full denture and had that lesion removed. But he kept his teeth for many, many years before that happened. We're not going to spend a whole lot of time on monomorphic adenoma. These are very rare. They occur in less than 3% of benign salivary tumors. Most of the time, a benign salivary tumor will be pleomorphic, not monomorphic. I first introduced you to adenoid cystic carcinoma in oral anatomy because I have a very personal connection to this horrible neoplasm. One of my very good friends lost her brother to this cancer when he was just 29 years old. He had had a lump around his parotid gland, and he went to the doctor. The doctor told him it should be biopsied. He didn't have any health insurance, and at that time it didn't hurt, so he put it off. But one day he began having lower back pain. He thought it was his chair at work. So he bought a new chair for work, but that didn't resolve his issue. He then began developing flu-like symptoms and ended up in the emergency room. And about a week later, he was back in the emergency room after his symptoms had failed to resolve. At that time, they did a scan and saw that he had tumors on his spine. So he was eventually diagnosed with stage 4 adenoid cystic carcinoma, and after a very courageous battle against this horrible disease, he eventually lost his life. Now, Chris's story is a very tragic one. Had his tumor been removed early on, he likely would have survived. This tumor does tend to recur, but it is slow growing and it can be removed surgically. But unfortunately, once this tumor metastasizes, it is basically not survivable. So this is another good reminder that we won't find what we aren't looking for. Many of our patients do not visit a medical doctor unless they are sick, but they do come to see us for preventive care. So we have not only a great opportunity, but in my opinion, we have a duty to use our knowledge and our skills to screen for these issues. We've been trained, and it is within our scope of practice to screen for them. Treatment, again, for adenoid cystic carcinoma is complete surgical removal. Mucoepidermoid carcinoma is the most common malignant salivary neoplasm. The most common malignant salivary neoplasm. And it features epidermoid cells, so hence where it gets its name, right? These have a better survival rate than adenoid cystic carcinoma, but treatment is really going to depend upon the tumor grade. So surgical excision, as you have figured out, is pretty standard with neoplasms when they're accessible. And for mucoepidermoid carcinoma, radiation therapy may be necessary for those higher grade tumors. What you want to remember on this one is that it is the most common malignant salivary neoplasm. So we're going to move into talking about odontogenic tumors, which means that these neoplasms are derived from tooth-forming tissues. Most of these tumors are benign, but some of them are very destructive. So just as a review, when teeth are forming, remember that they form as a result of an interaction between odontogenic epithelium and odontogenic mesenchyme. Most of these tumors contain epithelium, some mesenchyme, and some contain both. We're going to cover 4 epithelial odontogenic tumors in this lecture, but the one I want to spend the most time on is going to be Ameloblastoma, which I'll talk more about in just a minute. The other 3 that we want to make note of are calcifying epithelial odontogenic tumor, adenomatoid tumor, and calcifying cysts. Each of these have some distinctive features, which I have highlighted for you here. If you need to pause this to make your notes, please feel free to do that. And again, the one you most likely are going to see would be ameloblastoma, so we're going to talk more in depth about that one on the next slide. I was once working for a corporate dental office, and we had a young man on our schedule one day for a new patient exam. He was about 16 years old. He presented with what I initially thought was an abscess because he had a sinus drainage externally on his cheek, which was very swollen. So after taking his x-rays, it was very apparent that he had a large multilocular soap bubble lesion in the left mandibular molar area. It was very destructive. It was displacing his teeth. This young man had been in our system several years prior at another location. So we looked back at those images and we saw at that time, he was probably about 12 or 13 at that time, and he had had a very apparent early lesion present at that time. But it was not noted. It was not followed up on. And this young guy had been in that clinic several times to have fillings done by different providers, and nobody had ever noticed it. It was very obvious on both the pano and on the bite wings. Our doctor immediately phoned the oral surgeon and sent the x-rays from several years prior as well as the ones we had taken that day. They saw him the next day and biopsied that lesion, and this young man had a textbook case of ameloblastoma. He had to have his entire left jaw resected. He ended up having to learn to eat and talk again. He was disfigured as a result of his surgery. Although ameloblastoma is not a cancerous tumor, it does behave in a similar fashion. It's a very interesting tumor. The oral surgeon said that it was actually the biggest case of gross neglect that he had ever seen. And the last I knew about this case, the boy's mother had filed a lawsuit. There were several providers involved in the suit who had failed to diagnose this obvious abnormality. I don't really know whatever happened to him or to that lawsuit. This was about 10 years ago or so. So in the list of epithelial odontogenic tumors, this is the one you really want to remember the most and the one you're most likely to encounter in your career, even though they're still pretty rare. There are 3 mesenchymal odontogenic tumors that we're going to discuss. The first is an odontogenic myxoma, which is a benign tumor. And you'll notice in the picture here that these have a honeycomb appearance radiographically. They can cause tooth displacement, and they typically occur in younger people. So despite excision though, these tumors tend to have about a 25% recurrence rate. The next one is going to be a board alert. Central cementifying fibromas are also known as central ossifying fibromas. Board alert. You need to remember that central cementifying fibromas are also known as central ossifying fibromas. These guys are well circumscribed lesions. They are more likely to occur in women, and once they are excised, recurrence is rare, thank goodness. Cementoblastomas are also deemed the only true cementoma because they actually do produce cementum, and these typically do not recur once they have been removed. There are 3 mixed odontogenic tumors that we're going to discuss, 2 of which are on this slide, and I'll save the other one for its own slide because I want to spend a little bit more time on that one. Here we have an ameloblastic fibroma, which is a benign lesion that occurs more predominantly in males and in people under the age of 20. These tend to occur in the mandibular bicuspid premolar region. They're well defined. They can be either unilocular or multilocular, and once they are excised, the recurrence rate is low. An ameloblastic fibrodontoma has features of both a fibroma and an odontoma. It is a benign lesion. The average age is going to be about 10 years old, and there is no sex predisposition. So these are going to occur mostly in the posterior jaw, and they are well delineated lesions. Again, recurrence is going to be unusual once it has been removed. Odontomas are the most common odontogenic tumor. The most common odontogenic tumor. These are composed of mature enamel, dentin, cementum, and pulp. And there are 2 types of odontomas, compound and complex. You're going to want to know the difference between these 2 subsets. A compound odontoma consists of many small teeth. They might not be perfectly formed teeth, but they do have a resemblance of individual micro teeth. A complex odontoma has all of the features of a tooth, enamel, dentin, cementum, and pulp, but those tissues are arranged in one large mass, which doesn't have distinguishing features resembling a tooth. Both of these types of odontomas are usually found during adolescence, and there is no sex preference for these. Compound odontomas are usually found in the maxillary anterior region, versus a complex odontoma, which is found in the mandibular posterior region. So here is our second submission question. What is the difference between a compound odontoma and a complex odontoma? The soft tissue tumors we're going to move through pretty quickly. The descriptors I'm going to give are very overgeneralized, but that's because you don't need to be pathologists. You just need to have a general understanding of the meaning or origin of each of these neoplasms. For instance, lipoma. You should be able to recognize that this refers to a tumor of the adipose tissue. So as such, they will appear as a yellowish mass. A neurofibroma or a schwannoma, these are going to be tumors of the nervous tissue. You do need to know that the most common location for these will be on the tongue, intraorally will be on the tongue, as pictured here. So these can occur at any age, any sex, but once they are removed, they do not tend to recur. Granular cell tumors also appear intraorally on the tongue most commonly, and then followed by the buccal mucosa. These are benign lesions that derive from neural or mesenchymal tissue. A congenital epulis, you should remember this is one that is present at birth and has a predominance towards girls, which indicates that it may have a hormonal component. These are usually found in the maxillary anterior, and once they are removed, they do not recur. With tumors of the muscle, I really want to focus more on rhabdomyosarcoma. Anytime you see the word rhabdo, it's going to refer to muscle. This one is devastating. It's malignant. It's a neoplasm of the striated muscle, and it's the most common malignant soft tissue tumor of the head and neck in children. So we see lots of kiddos with this one, not lots of them, but one is too many, right? The text says that this has a poor prognosis, but again, this is an overgeneralization, and it really depends on the type of disease, the stage when it's found. This one does tend to grow very rapidly, and it is destructive. I've followed a couple of cases of rhabdomyosarcoma over the years, and almost all of them presented much like this picture here, where the eye is bulging as a result of the pressure of the tumor. It's just a very devastating disease. Hemangiomas are actually quite common. In fact, when I was born, I had a hemangioma on the top of my head.
Oh my God.
I still have a small lesion there today, but it is covered by my hair. For the most part, though, it resolved on its own. Some people call these like angel kisses or strawberry birthmarks. These lesions are highly vascularized because they are a benign proliferation of the capillaries. Lymphangiomas are benign tumors of the lymphatic vessels. These are less common than hemangiomas, and they tend to recur even when they are removed. We've already learned about Kaposi sarcoma in a previous lecture, but as a reminder, this one is a malignant vascular tumor, and it is associated with HIV. If you get a board question, it's probably going to ask you something related to Kaposi sarcoma in its relation to HIV. This one is caused by human herpes virus 8, and it is a very rapidly progressing disease. And we're going to talk about a few broad terms regarding tumors of bone and cartilage. An osteoma refers to a benign, compact bone lesion. These are slow growing, and often appear in the frontal sinus area, although I didn't put a picture of that in this slide. They are usually in the frontal sinus area. Multiple osteomas are associated with Gardner syndrome, which we learned in a previous lecture. An osteosarcoma, on the other hand, is a malignant tumor of bone. This is the most common primary malignant tumor of bone in patients under 40. So this one affects younger people. Often this tumor does present in the long bones of the leg. When it does present in the jaw, however, the survival rate is very poor. Now, similarly, a chondroma is a benign lesion of cartilage versus a chondrosarcoma, which is a malignant lesion. A chondrosarcoma also has a very poor prognosis when it is associated with the jaw. And finally, we have tumors of blood-forming tissues. Leukemia refers to a broad group of disorders which are characterized by an overproduction of atypical white blood cells. Leukemia can be acute or chronic. One thing that we might notice in someone undiagnosed is a diffuse gingival enlargement with persistent bleeding. So if you have a patient who doesn't respond to normal gingival debridement, they come back and their tissue looks exactly the same or worse, it's still bleeding very badly despite your effort for plaque control, then it's going to be a good idea to refer the patient to his or her physician for evaluation, because that would be a red flag for us. A lymphoma refers to a malignant tumor of the lymphoid tissue, and there are many types of lymphomas. This usually affects adults and is more prominent in men. Multiple myeloma is a malignant proliferation of plasma cells, which produce immunoglobulins. So eventually the bones are weakened from destruction by these neoplastic plasma cells. So leukemia, white blood cells, lymphoma, lymphoid tissue, multiple myeloma, plasma cells.
Okay guys, that's going to be the end of our lecture on neoplasms. Don't forget to like my video and subscribe to our channel so you don't miss any other future videos. See you next time.